You know that little bump you sometimes get on your eyelid? Maybe you've had one that sticks around for a bit.
Mm-hmm.
Well, today we're really zeroing in on one specific type, the Chalazion, often called a Meibomian cyst, right?
So we're cutting through the general noise of eye issues and diving straight into what makes a Chalazion, well, tick.
Right.
Think of this as your, let's say, streamlined guide. It's built from key revision notes, MSRA level stuff, aiming to give you the essential understanding quickly and effectively.
Okay, so our mission is pretty clear. Arm you, the listener, with a concise, hopefully memorable overview of Chalazion.
Yeah,
We'll break down what it is, why it happens, how you spot it, and what can actually be done about it. No fluff, just the critical bits.
nuggets, exactly.
So let's jump right in. What exactly are we talking about when we say Chalazion?
Okay, so at its core, a Chalazion is a non-infectious lump, usually painless too, that's important. Develops right there on the eyelid.
Non-infectious. That's the first key takeaway, isn't it? Helps separate it from a stye straight away.
Absolutely. That's the main distinction. So if it's not an infection, where's it coming from?
Good question.
It starts with a blockage in one or more of the Meibomian glands. Now, these are tiny glands. They sit inside the eyelids,
Okay.
and their job is to secrete this oily substance. It's called meibum.
Right, I've heard of that. Part of the tears.
Exactly. A really vital part of our tear film. It stops the tears evaporating too quickly, keeps the eye surface healthy.
Okay, so these glands get clogged up. What happens then? What's the sort of knock-on effect?
Well, when a Meibomian gland gets blocked and inflamed, the meibum can't get out properly.
Makes sense.
Instead, it kind of leaks out into the surrounding eyelid tissues.
Yeah.
And this triggers a specific type of chronic inflammation. It's called granulomatousinflammation.
Granulomatous. Okay.
Basically, it's the body reacting to this trapped oil, but reacting slowly over time.
So the oil gets stuck, the body reacts, and that's what creates the lump we see. Now, you mentioned it's different from a stye. Can we really nail down those differences? Because they can look similar at first, can't they?
They definitely can, especially early on. But a hordeolum, or stye, is fundamentally an acute infection. That's the key.
It's acute infection.
And there are actually a couple of types of stye to be aware of. There's the internal hordeolum,
Uh-huh.
less common, thankfully.
Uh-huh.
That's an infection inside the meibomian gland itself, almost like a tiny abscess.
Ouch.
Yeah. And then there's the external hordeolum, much more common. That's the typical stye you picture right on the edge of the eyelid. It's an infection of a lash follicle.
The base of an eyelash. Got it. So maybe a memory tip here. Chalazion Chronic, often cool or painless later on. Hordeolum Hot, meaning acute infection, usually painful.
That's a great way to put it. Chalazion Chronic, Hordeolum Hot. Perfect.
Okay.
And here's something else, sort of an interesting point. If someone keeps getting chalasia, like multiple ones, or they recur often, it could actually suggest there's an underlying issue. Maybe their meibum is naturally thicker, or its quality isn't quite right, making blockages just more likely to happen.
Ah, okay. So recurrent ones might point to something systemic or chronic going on. That's good to know. So let's dig into the etiology then. What's the root cause, the mechanism behind these blockages?
Well, the primary driver, as we've said, is that meibomian gland blockage. No question there.
Right.
And this often happens because the meibum itself, it just gets too thick. Or it can even solidify, like within the gland's duct.
Like the oil turning sort of waxy or something, too viscous to flow out.
Precisely. Exactly that. And this buildup of meibum then kicks off that inflammatory process we mentioned, leading to the formation of that cyst-like lump, the Chalazion.
Okay, that clarifies the how. Now, who's more likely to get these? Who's more susceptible? What are the risk factors we should be thinking about?
Yeah, good question. We can sort of group the risk factors into a few main areas. First, this is a big one, is poor eyelid hygiene.
Just not keeping the eyelids clean enough?
Yeah.
Essentially, yeah. Not regularly cleaning them can allow debris, maybe bacteria, to build up around the gland openings. Contributes to blockages.
Makes sense. What else?
Second, certain chronic inflammatory skin conditions. These have a really strong link. Things like blepharitis, that's general eyelid inflammation.
Okay.
Also rosacea, the skin condition causing redness.
Mm-hmm.
And seborrheic dermatitis, that common flaky skin condition. These often affect the eyelids too.
So it really highlights that connection between skin health generally and what happens on the eyelids.
Absolutely. If you have those conditions, you're definitely more prone to chalazia.
Okay, what's next?
Third, hormonal changes or imbalances can sometimes play a role. The evidence is maybe less strong, but it's a factor.
Interesting.
And finally, sort of looping back, any condition that fundamentally changes the quality of the meibum itself, makes it thicker, less able to flow, that increases the risk.
Right. Are there any sort of less common things? Rarer associations? Yeah, there are a few worth mentioning, although they are rarer.
Mm-hmm.
Things like pregnancy can sometimes be associated. Diabetes mellitus is another one,
Mm-hmm.
maybe affecting gland function or the oil itself.
Okay.
High cholesterol or hyperlipidemia. And then even less commonly, some systemic infections like leishmaniasis or TB or conditions involving immune deficiencies or certain viral infections. But these are definitely not the usual suspects.
Wow. Okay. That's quite a range. So thinking clinically then, say a patient comes in, history of rosacea, maybe some blepharitis, and they've got this painless eyelid lump. Chalazion should be right at the top of your list.
Exactly. That's precisely the kind of link to make. The underlying skin condition predisposes them.
Great. Okay. So we know the risk factors. Let's quickly trace the pathophysiology again, step by step. What's happening biologically?
Sure. So sequence is step 1, meibomian gland gets blocked, obstructed.
Right.
Block 2, the meibum, the oil, gets trapped. It accumulates inside the gland.
Builds up.
Step 3, this retained meibum leaks out into the eyelid tissue around the gland.
Leaks out. Okay.
Step 4, the body spots this leaked oil and mounts that inflammatory response, the granulomatous type we mentioned.
Inflammation starts.
Step 5, this causes localized swelling and the formation of that initial cyst-like lump.
A lump appears.
And then over time, this tends to become firmer and usually painless. That's the typical evolution.
Got it. Blockage, buildup, leakage, inflammation, lump formation, then firm and painless. That makes sense. Now, this is crucial. Differential diagnosis. Someone presents with an eyelid lump. What else could it be? How do we make sure we don't miss something?
Yeah, absolutely critical. The most common thing to differentiate from, obviously, is the stye, the hordeolum.
Right, the hot one.
Exactly. Remember those key differences. Chalazion, usually non-infectious, painless later on. Stye is acute, infectious, usually painful.
Okay. Besides a stye, what's on the list?
Well, and this is really important. You have to consider malignancy, especially if a chalazion seems chronic, keeps coming back in the exact same spot, or just looks a bit odd.
Yeah.
Unusual feature.
Malignancy, like cancer.
Yes. Specifically, sebaceous cell carcinoma. It arises from oil glands, so it can definitely mimic a chalazion. Also, basal cell carcinoma, another common eyelid cancer.
Wow, okay. That's a sobering thought. A chalazion that keeps recurring really needs a second look.
Definitely warrants careful assessment. Don't just assume it's another chalazion without thinking.
Okay, what else is in the differential?
You also need to think about other types of benign eyelid cysts. There are various kinds.
Right.
Also, other forms of eyelid inflammation or even different types of infection could present with a lump initially.
Okay.
And location matters, too. If the lump is near the inner corner of the eye towards the nose,
Yeah.
you need to consider things affecting the tear drainage system, like dacryocystitis, which is inflammation of the tear sac, or canaliculitis, inflammation of the little tear duct.
Ah, okay. Location gets clues.
Absolutely.
Yeah.
And just to really hammer it home, any chalazion that's chronic, keeps coming back, or looks atypical, you should strongly consider a biopsy. Sending a sample off for histology to rule out an underlying eyelid tumor.
Got it. Biopsy for recurrent or weird ones. Are there specific tumors you'd list?
Yeah, the main ones to keep in mind are sebaceous gland carcinoma, basal cell carcinoma, squamous cell carcinoma, melanoma, though rare on the eyelid, Merkel cell tumor, and potentially lacrimal sac tumors if it's in that inner corner area.
That's quite a list to remember. Is there maybe a simpler way to frame those differentials? A mnemonic, perhaps?
Well, you could try thinking BLIST. How about that?
BLIST. Okay, what's that stand for?
B for benign lumps like other cysts, I for infections, mainly styes, S for skin cancers, the sebaceous, basal cell, etc., and T for tear duct issues like dacryocystitis.
The list. Benign lumps, infections, skin cancers, tear duct issues. I like it. That's actually really helpful for organizing things. Okay, shifting gears slightly. How common are chalazia? What's the epidemiology look like?
It's a bit tricky. The exact prevalence isn't super well defined in the literature, but we know they're pretty common. They can affect people of all ages, from kids to older adults.
Okay, fairly common across the board.
Yeah. And as for who gets them more often, well, the epidemiology really just mirrors those risk factors we already talked about.
Ah, so people with chronic blepharitis, rosacea, seborrheic dermatitis.
Exactly. They have a higher incidence. Also, potentially pregnant individuals, people with diabetes mellitus,
Right.
And then those rarer associations like hyperlipidemia or certain infections also factor into the overall picture, but they don't drive the main numbers.
So, common condition, particularly if you've got those underlying eyelid or skin issues or certain systemic things like diabetes. Okay. Now, clinically, what does it actually look and feel like to the patient? What's the typical presentation?
Okay, the classic picture is a painless lump on the eyelid itself, but usually a bit away from the actual edge, the lid margin.
Not right on the lash line, typically.
Correct. Patients often notice it gradually getting bigger over days or weeks, and it tends to become quite firm to the touch.
Firm and painless.
That's the typical later stage. Now, in the very beginning, there might be some mild or moderate eyelid swelling, maybe even a bit of tenderness, but that usually settles down.
Okay. Any other symptoms?
Occasionally, yeah. If the chalazon gets quite large enough to actually press on the front of the eye, the cornea, it can sometimes cause slightly blurred vision, just from the pressure distorting the cornea shape a bit.
Okay. That's a practical point. And can people get more than one?
Oh, definitely. It's quite possible to have multiple chalazion at the same time. It can be on the upper lid, lower lid, even both eyes. Bilateral presentation happens.
Right. And what does the doctor see on examination?
Well, the key maneuver is gently averting the eyelid, flipping it inside out.
Okay.
When you do that, you can often see a discrete, quite well-defined lump. It's usually immobile, roundish, and sometimes has a slightly yellowish appearance through the conjunctiva.
And what about other signs like redness or discharge, things you see with infections?
That's a really important point. In a typical, uncomplicated chalazion, you don't expect to see things like ulceration on the surface or bleeding or those little spidery blood vessels called telangiectasias.
Okay.
And critically, there shouldn't be significant tenderness once it's established and no pus-like discharge. The absence of those signs really helps point away from an infection like a stye.
Right. But you did mention that larger ones can cause blurred vision from corneal pressure.
Exactly. It's a mechanical effect, not infectious. Good to explain that to patients if they experience it.
Okay, so painless, firm, away from the lid margin, no discharge. That's the picture. How do we actually diagnose it then? Are specific tests usually needed?
For the vast majority of cases, nope. The diagnosis is primarily clinical. It relies on taking a good history from the patient and doing that careful eyelid examination.
Just looking and feeling, basically.
Pretty much. Now, as we hinted before, in the very early days, maybe the first day or two, it can sometimes be a bit tricky to tell a chalazon apart from a hordeolum just by looking. They can both be a bit red and swollen initially.
Right, so how do they declare themselves over time? How do you tell them apart later?
Well, over time, the chalazon tends to settle into that classic small, non-tender nodule, usually located a bit more within the main part of the eyelid away from the edge.
Okay.
An external hordeolum, the common stye, usually stays painful and stays right at the eyelid margin, often clearly linked to an eyelash.
Right at the edge.
Yeah, and an internal hordeolum, that might mimic a chalazon a bit more with pain, redness, swelling, but usually those symptoms are more intense. Plus, an internal hordeolum might actually rupture spontaneously on the inside surface of the eyelid, conjunctival side, releasing pus.
Okay. So location, pain persistence, and potential rupture help differentiate.
Precisely. And because the diagnosis is usually straightforward based on these clinical features, specific investigations like blood tests or scans, almost never needed.
Okay.
But, and this is the important caveat again, if you have a chalazon that keeps coming back in the same spot or it looks atypical in any way,
Then you investigate.
then you absolutely consider sending a tissue sample for histology, a biopsy, to definitively rule out those rarer possibilities, especially eyelid tumors.
That makes perfect sense. If it keeps recurring, you need to be 100% sure. Okay, let's move on to management. What can actually be done for a chalazon? What are the treatment approaches?
We can think about management in stages, really. There's the initial management and self-care, then medical options if needed, and finally, follow-up and knowing when to refer.
Okay, what's initial management?
The cornerstone is warm compresses. Applying warmth to the eyelid helps liquefy the trapped meibum, encourage drainage, and reduce inflammation.
Worm compresses, got it.
Good eyelid hygiene is also vital, especially if there's underlying blepharitis. Sometimes, if there's a hint of secondary bacterial infection, maybe a bit of crusting, an antibiotic ointment might be used for a short time.
Okay.
And then for chalazion that just won't go away or are causing significant bother, surgery becomes an option.
Right, so focusing on that self-help bit first, what exactly should people do at home?
The advice is pretty straightforward. Apply a warm compress, like a clean flannel soaked in warm water, not too hot to the affected eyelid. Hold it there gently for about 5 to 10 minutes.
How often?
Usually twice a day is recommended. And after the warm compress, some gentle massage of the eyelid over the area of the lump can also help. Just trying to encourage that blocked gland to drain.
Okay, warm compress, gentle massage, anything else?
And, as mentioned, if someone knows they have blepharitis, keeping up with their regular eyelid margin cleaning routine is really important, both for treating the current chalazion and preventing future ones.
Right. Keep it warm, keep it clean, maybe a gentle massage. Simple enough. What if that doesn't work? What are the medical options a doctor might offer?
Okay, several possibilities here. One common one is a minor surgical procedure. It's usually done under local anesthetic, just numbing the eyelid.
What does it involve?
A small incision is made, typically on the inside of the eyelid, to avoid a visible scar, and the contents of the chalazion are drained or scooped out. That's called curettage.
Okay. Incision and drainage.
Exactly. Another option, particularly for smaller, softer, maybe more recent chalazia, is an injection of a corticosteroid, like triamcinolone, directly into the lump.
A steroid injection.
Yeah. It helps reduce the inflammation and can shrink the chalazion. Sometimes it avoids surgery.
Interesting.
For larger or maybe multiple chalazia, sometimes a combination is used, curating out the contents and injecting a bit of steroid afterwards.
Okay. Any other medical approaches?
Well, if someone has persistent chalazia and it seems clearly linked to underlying rosacea or maybe severe seborrheic dermatitis,
Yeah.
sometimes systemic antibiotics like tetracyclines taken orally for a longer period might be prescribed. Not really to treat the chalazion directly as an infection, but more to manage the underlying chronic inflammation from the skin condition.
Treating the root cause in a way. Got it. And when does someone need to be referred on to a specialist, like an ophthalmologist?
Referral is definitely needed in certain situations. Firstly, if there's any suspicion of orbital cellulitis, that's a serious infection spreading behind the eye. Red flags like severe pain, fever, vision changes, eye movement problems, that's an emergency.
Okay, urgent referral for suspected orbital cellulitis.
Absolutely. Secondly, as we keep stressing, if there's a possibility of malignancy, the recurrent lesion, the atypical appearance they need to see ophthalmology for assessment and likely biopsy.
Makes sense.
Also, if chalazia are just persistent, they keep coming back despite good conservative treatment, or if a child develops a really large chalazion that might be pressing on the eye and affecting vision development, referral is warranted.
Right, persistent, recurrent, or vision affecting in kids.
Exactly. And managing an internal hordeolum that isn't clearing up might also need specialist input, potentially for incision and drainage under controlled conditions.
Okay, that's clear. So if it's not getting better, if you're worried it's something else or it's impacting vision, get specialist advice. Can we have a quick mnemonic for those initial self-care steps again?
We said warm, massage, clean earlier, didn't we?
Ah, yes. Warm compresses, gentle massage, consistent eyelid cleanliness. Perfect. Simple and actionable. Now, overall, what's the prognosis? What's the typical outcome for someone with a chalazion?
Generally, it's really quite good. The vast majority of these will resolve on their own, or with those simple conservative measures like warm compresses.
How long does it usually take?
It can vary, but often within a few weeks to maybe a couple of months. Patience and consistency with the warm compresses are key.
Okay, good prognosis mostly.
Yeah, but it's important to manage expectations. Recurrence is possible, especially, as we know, in people who have those underlying risk factors, the blepharitis, the rosacea.
So even if one clears up, another one might pop up later down the line if the underlying conditions aren't managed.
That's definitely a possibility to be aware of, yes.
Okay. And finally, let's just touch on complications. Are there any significant risks associated with having a chalazion? We know it's usually benign, but...
Right. Complications are, thankfully, pretty rare.
That's reassuring. But what could potentially happen?
Well, you could get persistent inflammation in the eyelid around it. Sometimes, although it starts non-infectious, it can get secondarily infected with bacteria. Cosmetic concerns are also a factor for some people, just the appearance of the lump.
Yeah.
And as we mentioned, those really large chalazia,
Yeah.
they can physically press on the cornea and induce astigmatism, blurring vision, or they can cause a mechanical ptosis, a slight drooping of the upper eyelid, just due to the weight and bulk.
Right, the mechanical effects.
And we also touched on the very rare but serious risk of a secondary infection spreading beyond the eyelid, causing perceptal or even orbital cellulitis that needs urgent treatment.
Okay, serious infection spread is rare but possible. Any risks with the treatments? Like the surgery?
With the minor operation, as with any procedure, there are small risks.
Mhm.
Things like bleeding, infection at the site, maybe very rarely some minor trauma to the tear drainage channels if it's near the inner corner, or extremely rarely perforation of the eye itself. But these are very uncommon in experienced hands.
Understood. So overall, complications are rare.
Exactly. Probably the most common actual issue people face long-term is simply the chalazon coming back. Recurrence is the main thing.
Right, recurrence. Okay, so let's try and wrap this up. To recap our deep dive today. Chalazion. It's common, usually benign, comes from a blocked Meibomian gland, presents as a painless lump, typically away from the lid margin, often gets better with just warm compresses and good hygiene.
That's the gist of it. And crucially, remember to distinguish it from a hordeolum, the hot infection.
Right. And always keep malignancy in the back of your mind for those recurrent or atypical ones. Biopsy if unsure.
Couldn't have said it better myself. Conservative measures are key, but know when to seek medical help or refer.
Fantastic. A really clear and practical overview. Now, just a final thought for you, our listener, as you're revising or just thinking about this. Maybe reflect on your own eye comfort and hygiene habits. Are there small things you could maybe tweak to promote better eyelid health? And perhaps if you've had recurrent chalazia, have you ever chatted with your doctor about potential underlying factors like blepharitis or rosacea?
Those are excellent points for reflection. We really hope this deep dive has provided a focused, high-yield resource for your learning and revision on Chalazion.
Definitely. And remember, if you're looking for more top-notch MSRA revision resources, do check out PathophysiologyStep-by-Step.
And for a fantastic range of free MSRA study materials and questions, head over to freemsra.com.